Thanks for coming back. So, as I was saying, this is the drug of choice for the treatment of the initial or the recurrent episodes of infection, and they need to be taken at the very onset of symptoms. So, similar antivirals are famciclovir or valacyclovir. Those are only available in oral form, and the valacyclovir is actually a prodrug that is metabolized to acyclovir in the body. It does have better bioavailability and less frequent dosing, so we give that medication 3 times a day compared to acyclovir, which is 5 times a day. So that's something that the provider might think about when they're ordering these drugs. With ganciclovir, it's also called cytovine. This is a synthetic nucleoside analog used to treat infection with CMV or cytomegalovirus. It comes in oral or parenteral forms. For CMV retinitis, it also comes in an ophthalmic form that is surgically implanted. It's called a Vitrasert. And of course, that's done by the ophthalmic surgeon, the ophthalmologist specialist. With our ganciclovir, there is bone marrow toxicity that can occur, and with the roscarnet and the citifovir, there's renal toxicity that can occur. So the bone marrow toxicity and the renal toxicity are actually dose related, so there's often dose limiting that can occur with these drugs, and we really have to consider toxicity when we're ordering this. So the provider is going to think about those before they order these. And it'll depend on bone marrow function, renal function, those sort of things. With our antiviral drugs, still talking about the non-HIV, we have our NEURAMINIDASE inhibitors. This is oseltamivir or Tamiflu and zanamivir. This is Relenza. These are active against influenza types A and B. What they do is they, just like the others, reduce the duration of the illness. With oseltamivir, it can cause nausea and vomiting, and the zanamivir causes diarrhea, nausea, and sometimes sinusitis. But again, treatment should begin within 2 days of the influenza symptom onset. We have our RIBAVIRIN as another non-HIV antiviral drug, and this is a synthetic nucleoside analog that actually interferes with both the DNA and the RNA synthesis. So it has a pretty broad spectrum of antiviral activity when we compare it to the other antiviral drugs. It can be given orally or by oral or nasal inhalation. And the inhalation form, the virazole, is what we use for hospitalized infants who have RSV infection. The oral forms have recently also become available in the treatment of hepatitis C. And as I said, we'll talk about hepatitis more in chapter 47. Let's talk about HIV and AIDS. Now, you probably recall from our discussion in LVN 121 that HIV is the virus that causes AIDS. And so infection with HIV results in the eventual destruction of the immune system. So remember how viruses bind to a cell and they change? Well, HIV binds to the CD4 plus T receptor cells in conjunction with the cellular co-receptors, chymokine CC motif receptor 5, or what we'll call CCR5, or the CXC chemokine receptor 4, or CXCR4, and they enter and infect the immune cells in the body. So early in HIV infection, those cells counts remain above the 500 cells, and they remain normal, but over time, this immune system weakens. And that's what we're measuring when we look at the ELISA. We're looking at this enzyme-linked immunosorbent assay that detects exposure to HIV based on the presence of the human antibodies to the virus in the blood. Remember that it is a retrovirus. And you'll remember that the first cases of AIDS in the United States were recognized in 1981. It carries a lot of stigma as it was originally identified in homosexual men in the 80s, but the virus we know affects men and women of all races, all ethnicities, and all sexual orientations, as well as infants, children, and adolescents. You may also remember that there are two of the HIV strains. The HIV-1 is the type of virus found predominantly in the United States, with HIV-2 being relatively rare in the United States, except among immigrants from West Africa, where the predominance of cases of HIV-2 originate. Now, HIV-2 is biologically similar to HIV-1, but it shows reduced virulence. So it has a slower rate of the CD4 T cell decline. Blood banks now routinely test both for HIV-1 and HIV-2. So you'll remember it's a bloodborne pathogen transmitted by sexual activity, intravenous drug use, or perinatally from mother to child. When we have HIV, there are 4 stages to the HIV infection. Stage 1, we may have asymptomatic infection. Stage 2, we'll see early general signs and symptoms of the disease. Then stage 3, more moderate symptoms, with stage 4 being the very severe symptoms, often leading to the death of the patient. So I'm not going to, like I said, I'm not going to belabor that here, but I did want to talk about that. And we'll talk about as well the patient that has HIV dies from the opportunistic infections, right? The protozoal, the fungal, or the viral infections, which can be things like toxoplasmosis of the brain or other areas of the body. Fungal infections like the candidiasis of the lungs, the esophagus, the trachea, the pneumocystis, we have pneumocystis carinii pneumonia, and then we have the pneumocystis jirovecii pneumonia. There are other types of opportunistic pneumonias that can occur, or fungal infections that can occur. We have the viral cytomegalovirus or herpes simplex infection and other viral infections that can overwhelm this person's system. They can be bacterial, including our mycobacterial infections. So we can see extrapulmonary TB. And by that, I mean that TB doesn't just live in the lungs, it can live in other parts of the body. We can see the opportunistic neoplasias like the Kaposi sarcoma or other rare cancers. And ultimately, we see HIV wasting syndrome, where the patient has major weight loss, chronic diarrhea, and chronic fever. So we treat using a thing called HAART. That's highly active antiretroviral therapy. And this includes at least 3 medications, or what we call cocktails. And we use this because these medications work in different ways to reduce the viral load. You see, you'll remember, once the HIV enters the healthy CD4 T cells, the cell then becomes infected and the HIV begins its replication activity. It converts its own genetic material, that RNA, into the complementary DNA strands. So we have this retrovirus. And this RNA-dependent DNA polymerase enzyme reverse transcriptase, or RT as we call it, is actually it's kind of a signature or the hallmark of the retroviruses. So the viral DNA then becomes double-stranded, and it's incorporated into the host cell genome by the viral integrase. And so what these drugs have done, the antiretroviral medications were developed to inhibit this genomic integration step in the viral replication process. Now, mammalian cells do not express reverse transcriptase. This enzyme was the first retrovirus-specific target for the HIV medications. And we had the nucleoside and nucleotide RT, or the reverse transcriptase inhibitors, as well as the non-nucleoside RT inhibitors. And they interfere either with the DNA template primer activity of this reverse transcriptase, or they serve as a competitive chain terminator by elongating the viral DNA strands. But what's important is that the RT lacks this repair, this histone repair enzyme. And so what we have is a high rate of uncorrected mutations during each of the cycles of the viral's DNA replication. So there's this rapid development of resistance to HIV or by HIV to the antiretroviral agents. And that is particularly in the presence of non-compliance, or if we have monotherapy. So we do this as a combination therapy, and we need to have a high degree of patient's compliance for these medications to work. With the antiretroviral drugs, we'll see that there are 5 classes of these antiretrovirals, the reverse transcriptase inhibitors, or the RTIS. These block the activity of the enzyme, the RT, by preventing the production of the new viral DNA. There's the protease inhibitors. They inhibit the protease retroviral enzyme, thereby preventing viral replication. We have the fusion inhibitors that inhibit the fusion, preventing then the viral replication. We also have entry inhibitors, and so they work on that CCR5 co-receptor as an antagonist, and our HIV integrase strand transfer inhibitors. So don't fret, table 40-4 in your textbook does list the antiretrovirals that are used to treat HIV by these classes. So some examples of the drugs are listed here. You will also find these in that table. We're not going to go into each one of these, but let's just talk about them globally. Because they're antiretroviral, they have different adverse effects. They're very numerous and they can vary with each drug. But remember, we're giving these in a cocktail. Many times the drug therapy is modified because of the adverse effects. So the goal is to find this regimen that is going to best control the infection, but have for the patient a tolerable adverse effect profile. The medications will also sometimes need to be changed during the course of the illness. Again, the HIV does develop a resistance to these pretty quickly because of the way that it is, the way that this virus behaves as a retrovirus. Other viral infections that you may see not treated with HIV drugs, but non-HIV, are not as prevalent, and they're no longer really as novel as they once were. And those are avian flu or West Nile virus, SARS, severe acute respiratory syndrome, and H1N1 or influenza, the swine flu. Let's talk quickly about some nursing implications. Before beginning therapy, we want to make sure we've done a thorough assessment of the underlying disease, medical history, including allergies, assess the baseline vital signs. Nutritional status is really important. Assess for contraindications or conditions that may indicate cautious use, as well as potential drug interactions. Be sure that we're teaching proper application techniques for any ointments, aerosol powders, or any of those things. Emphasize hand washing before and after administration of medications to prevent site contamination or spread of infection. If we're applying a topical, instructing the patient to wear a glove or finger cot when applying these. Instruct them to consult their prescriber before taking any other medications. A lot of these drugs will interfere or will not be productive with other medications. Always emphasizing the importance of good hygiene and informing the patient or reminding them that antiviral drugs are not cures, but they do help to manage the symptoms. We want to instruct our patients of the importance of taking these medications exactly as prescribed and for the full course of treatment. They are to start therapy with the antiviral drugs at the earliest sign if they're being treated for genital herpes or herpes zoster. This is why often you'll have prescribers that will just go ahead and order them an extra supply, because by the time they get into the doctor's office, it's too late for that to really be effective. We want to monitor for adverse effects and teach our patients what the effects are. They're varied and specific to each drug, so that's dependent, as well as the therapeutic effects, which is going to vary depending on the infection. But we can have, for example, with AIDS, a delayed progression of the AIDS or other viruses and decrease in their symptoms. So if you have questions, you know how to get a hold of me. Email, text, call, or post something in the discussion forum, and I'll look forward to seeing you soon.